Australian Mpox update. My name is Amy Rendell. I use she, her pronouns, and I'm currently the Acting Coordinator of Population Health and Community Development team at WAAC. And I'm here with our clinical nurse consultant and nurse educator, Gary. Would you like to introduce yourself, Gary?
Hi, everyone. Some of you will know me, but this is also being recorded, so for people who haven't met us. Yeah, I'm Gary. I'm one of the nurses here at the M Clinic. I've been with the clinic since its inception, and I'm also very pleased to be the nominated nurse educator for WAAC. And yeah, so this is our first Mpox presentation. So Amy's put a lot of work into the slides. So hopefully you're going to find it interesting and helpful in your practice.
Cool. Thanks, Gary. Before we get started, I would like to acknowledge the traditional owners of the lands that we are all calling in from today. So today we are joining from the lands of the Whadjuk people of the Noongar Nation. We're based here in Booldoo in West Perth, and pay our respects to elders past and present, and recognise that always was and always will be Aboriginal land. And I'd like to extend those respects to any First Nations people joining us today for the session, watching online, and also the traditional owners of the lands that you'll be calling in from today right across the state. So before we do get started, a little bit of housekeeping. So as I mentioned, this session is being recorded. So we have started recording for today. So we ask if you are able to please keep your microphones muted and also your cameras off as well for the duration of the session. There will be time for questions at the end where we can stop the recording and you can ask if you would prefer to. Otherwise, if you do have any pressing questions, we ask if you just able to pop it in the chat. We will monitor the chat as much as we can throughout the session today. In case we aren't able to get to it at that time, that way at least it's out of your head and we can address it afterwards. So there will be time though to ask questions at the end. So again, please keep microphones off. I jumped ahead there. If you do have any questions, there's no such thing as a silly question. We know that everybody's here to learn. We have people from many different professional backgrounds joining today. For some, this may be your bread and butter. For some, this may be something that you're very new to and don't know much about Mpox. So everyone's here to learn. There's no such thing as a silly question. If you're thinking it, guaranteed other people are probably thinking the question too. At the end, we will have an online evaluation. So there will be a QR code that will be at the end of the session. We ask if you could please take a moment to complete that. This, as Gary said, this is our first of the Mpox webinars. We have done them on other topics. If you'd like to know more about those, I can send information out. But this just helps us to continually improve the sessions and the content we're able to deliver to you all. So we really appreciate any feedback you have. Before we do get started as well, just lastly, a content warning that we do have some clinical images that will be used in the presentation today. We'll give another warning before we do get to those slides, but just letting you know now, in case you're eating your lunch or you are working in a shared office space, that there will be some images of symptoms that will be coming up shortly in the presentation. So that's your first warning now. So just the overview. So we'll go through the origins of Mpox and the virus, what and to what it is, to where it came to, what it is today. We'll look at the epidemiology in Australia and specifically in WA. We'll then look at how transmission occurs, the signs and symptoms, how testing is done in your practice, means of prevention, and then also at the end we have some resources and referrals. So there will also be some more that will be sent out to you in a follow-up email after today's session. Oh, alrighty. So that is all the housekeeping and everything out of the way. So we will get started now. So just admitting everyone that's coming in. So origins of Mpox. So Mpox is a zoonoses, or it's an infection that's passed between humans and animals and vice versa. You can see there, so it's an enveloped double-stranded DNA virus. It is technically not an STI or sexually transmissible infection by definition, but rather it's defined as an infection associated with sex. So it is known to be passed on through intimate contact, close intimate contact, and in some instances, or many instances, sexual contact. But it's not its own means of transmission, or its only means of transmission, and it's not, so therefore not defined as an STI specifically. However, it is sometimes tested in amongst other STI testing, which we'll get to in a little bit later. So it's part of the orthopox virus I was going to say community family group there, which also includes smallpox, and then also the virus that's used to produce the smallpox vaccination, and also cowpox virus as well. So many people might be familiar with smallpox being eradicated through vaccinations and through vaccination efforts many years ago. And this is kind of the first of kind of the big orthopox kind of viruses that have come up since the eradication of smallpox. There's two different clades, so different types of Mpox. So clade 1, formerly like in the Congo Basin region, Central African clade, historically has more severe disease associated with it. And you can see there a higher mortality rate, and on average between 3 to 5%. There's then also clade 2A and 2B, so they're formerly known as the West African clade. These historically have a less severe disease associated with the infection and has that lower mortality rate there. And you can see there clade 2B has a less than 1% mortality rate outside of Africa. With the outbreaks that we've seen in recent years, these have mostly been associated with clade 2B. These are the outbreaks talking about in the USA, Europe, and in Australia within our context. There has been other outbreaks more recently of different clades as well, but they are more refined to specific regions. So today we'll be mostly speaking to that clade 2B. For those who are a little bit of history nerds like me, a little bit of a history of the outbreak. So again, like I said before, following the eradication of the smallpox vaccine, so smallpox virus, because of the vaccine in 1980, the subsidization of the smallpox vaccination programs, Mpox has kind of emerged as the next significant orthopox virus in public health concerns. So it was first discovered in 1958. The first human case was documented in 1970. As you can see there, smallpox was eradicated in 1980. Then there started to be increases in cases in the Democratic Republic of Congo in 2005, and then started to re-emerge in other parts of Africa. For example, there in 2017, re-emerged in Nigeria. In May of 2022, it was when it was declared the first global outbreak of Mpox clade 2. And we have mostly exclusively seen in Western countries or in countries named before, so USA, Europe, and Australia, more cases diagnosed amongst MSM, men who have sex with men, communities and populations. And this is separate. There has been a separate clade 1 outbreak that was commenced in 2023 in some African countries as well. But only very few cases of the clade 1 have been detected in Australia. And there's been no evidence of sustained transmission to date. And you can see here, so as of 2024, over 20 countries reported Mpox since 2022. Looking at it specifically within Australia, so global outbreak has primarily affected gay and bisexual men and who have sex with men populations, but hasn't been just amongst those populations. It's spread and mostly has been spread person to person through sexual networks. So again, an infection associated with sexual contact. So cases identified on the 20th of May in 2022, that was the first time the virus had been detected in Australia. And almost all these cases, again, have been that clade 2. And most infections as well reported in Australia have been acquired within Australia as well, so not from overseas transmission. In WA, all notifications to date, or as of end of 2025, have been male. Mostly in the metro area, there have been some regional cases as well, and the median age between 30 to 34, but the kind of average range between 20 up to 59 years. Of course, it can vary either side of that as well. In Australia more broadly, so there was a spike in both 2022 and 2024, and majority of these cases were in New South Wales and also in Victoria. And mostly, again, of these were cases amongst males, but also there was a small percentage of females diagnosed as well with Mpox. So you can see there, so similar kind of trends there, but we had kind of that lower caseload early on, and have been able to kind of have still had an increase in the number of notifications there, but we have been able to kind of maintain it through the vaccine efforts and prevention efforts that you'll hear about a bit more soon. So, as I said before, so Mpox is a zoonosis, so it's a virus can be passed between animals and humans and vice versa. Between person to person, transmission can occur when a person comes in contact with the virus, again from an infectious person, animal, or materials containing or contaminated with the virus. So it can be from that direct contact with infectious materials. So it can be through fomites, so contaminated objects that can be bedding, clothing, towels. And sometimes it might be unclear, the transmission, if there's any bodily fluids involved there, so mostly through fomites that we said there, which I just listed. So I'm talking myself in a circle there, missed my notes. Other way as well through respiratory transmission, so particularly during prolonged face-to-face contact as well. And then also with direct contact with infectious material from the skin lesions themselves. So these include through broken skin or mucous membranes. So that can be respiratory tract, nose, mouth, genitalia, anywhere where those mucous membranes may be exposed to infectious skin lesions. So how Mpox kind of works. So symptoms, it can take anywhere between 5 to 21 days for the first symptoms to appear. It is a self-limiting infection, so symptoms generally last about 2 to 4 weeks. The incubation period, again, so it can be a range of up from 5 to 21 days, and it can be infectious or spread to others from up to 4 days before symptoms do start. So again, beginning with the onset of symptoms, it could be either the rash or other symptoms that might appear, which we'll go through in a moment, and will remain infectious until the rash has resolved or lesions have resolved, lesions have formed scabs and fallen off. So the Mpox is considered infectious, again, like I said, until all scabs have fallen off, usually takes between 2 to 4 weeks, until all symptoms have gone, and then also after a positive result as well, after 21 days, if there's no symptoms there as well. So you can see here a little timeline there that we've clicked from this website here. That shows a bit of an overview, generally what might be expected with a timeline. So, sorry, I probably should have given that second warning there. So there will be some clinical images now. So I'll pass over to Gary for the signs and symptoms.
Okay, excuse me. So, sorry about this. So one of the things that can be a bit confounding, especially if you've done, I haven't done a lot of testing in sexual health, is that the rash and the lesions can vary. So sometimes we look at a certain rash and we go, is that molluscum, which is a different viral infection? Then we could think, oh, that's a rash that looks like herpes. Is it a rash that looks like syphilis? So you've got your typical lesions and then ones that you're like, not sure. So these, so the images there are quite typical. So what we would call the pox-like lesion, usually indented in the middle, and can be associated with a surrounding rash. So there are occasions where people are asymptomatic, but let's ignore that for now. So the lesions can come up anywhere on the body. If people are really unlucky, the lesions can come up in the mouth or the rectum. And excuse me, sorry. So in those situations, the lesions can be so painful that people can't eat or swallow or defecate, and can be incredibly debilitating. In general, though, the ones that we've seen have been external skin rashes. Some people get a prodrome, so mild to moderate illness, where you get fevers and headaches and muscle aches and joint pains, generally flu-like symptoms, also potentially with swollen lymph nodes. So some people can be very mildly unwell, as I think I said, through to moderate to severely unwell, where it can be quite debilitating. So we've seen these lesions that have come up, a few lesions on the body, not very unwell. People will get over it without an issue. Through to, we've got another picture coming up in a second. This is what I call my scary photo when I have clients that are like, no, there's not much Mpox around. I'm not too worried about it. And I go, well, this is one example. And one thing that we do need to stress to people as well, that if these lesions become infected with a bacteria, there's a potential that it can lead to permanent scarring. So some of our clients have been rather conscious of their appearance and have decided, okay, that's a good reason to get the vaccine. So if there's any other questions about signs and symptoms, etc., if I haven't covered everything that is clear enough, please put it in the chat or ask us at the end. All right, I'm sorry about this. So, as Amy's already said, the majority of the cases around the world, but also in Australia, outside of Africa, have been among men who have sex with men. And my light-hearted comment is always, again, bisexual men in general, not all, tend to be very sociable and have lots of afternoon tea parties when they go to pride events. So it just obviously multiple partners will increase the risk of transmission. So when do you test? So I guess for our clientele, so we primarily see gay, bisexual men, transgender, and other people within those sexual circles. So what where you need to be suspicious is in a situation where somebody has said, I am a contact, or I've been contacted that somebody I've had sex with has Mpox, and they may have symptoms, and the timeline within the previous 21 days, and they're presenting with symptoms, then you're going to be potentially suspicious about Mpox. So if there's sexual contact with somebody within that group in the 21 days prior to symptom onset, or in situations where there's been sexual contact, other physical contact, etc., with people at certain social events such as pride events, parties, etc., where there have been confirmed cases. So this is when you're going to think of testing, even if people don't have symptoms, and I'll mention that in a second. So, and of course, if you've got clinical evidence based on the signs and symptoms that we've discussed there. So if we've had people that have been direct contact, but they're currently asymptomatic. So in a situation like that, where there are no lesions present, they're not otherwise unwell, then we do a nasopharyngeal swab, which people hate. And we've also had people do a semen sample. So there's occasions sometimes where people may be asymptomatic at the very beginning or remain asymptomatic, which can be a bit of a problem. So this is a way to check if the virus is present, if symptoms are not present. So with anyone that's presenting with compatible symptoms, and also particularly if they've got a good history of potential contact. So where there's anogenital lesions, where they've got a rash, and even occasions we've seen people with rather nasty symptoms of proctitis, then you are going to be wanting to consider that, particularly within this, I hate using the term, but high-risk group, so to speak. So always need to consider any differential diagnoses, things like syphilis and herpes, and can be difficult to differentiate. So I think the default needs to be, I think this might be Mpox, but I'm also going to test syphilis. I'm also going to test HSV. There are other viruses which we could get, like chickenpox, for example. Molluscum is another moderately common virus. It's usually in children, but can present with very similar symptoms. So it's always good to definitely consider syphilis, herpes, and varicella, which is the chickenpox. So, and also anyone presenting with those symptoms, if they're going to think, okay, when was the last time they had an STI check? So HIV, syphilis, serology, chlamydia, gonorrhea should always be thrown into the mix. Okay, so testing is by PCR. And so it's a dry swab. Do not use a culture swab, please. So as I've said, we should always include herpes and syphilis. Can all be done on the same swab. You don't need to take separate swabs. There can be some advantage of taking a couple of different swabs. So looking if you can see lesions that are in different stages of evolution. So one that might be beginning, one that's advanced, and one that may be healing. So get at least two different lesions. So what you also need to do is make sure that you de-roof the lesion if at all possible. Don't use a scalpel, because there's been some cases where healthcare workers have gone, oh, oops, I've just cut myself with the scalpel. So just use the dry PCR swab. And as I've said there, it says don't use transport medium, don't use a culture swab, please. So the specimens need to be double bagged and they need to be labelled Mpox samples so that when they get to the lab, they're going to take appropriate precautions where they'll use eye protection and a mask and gloves to make sure that there's no potential transmission when they're opening up the samples. So I've already mentioned there about the asymptomatic testing with the nasopharyngeal swab and semen sample. And even if people do present with symptoms, always do the nasopharyngeal swab. The semen sample we would keep for people that are absolutely definitely asymptomatic. But if you're testing one of the rashes, then forget the semen sample, but the nasopharyngeal swab for sure. So with the PPE, if somebody fits the epidemiological criteria and are symptomatic, then we've had people that call up and say, look, I've got these lesions, I'm a bit unwell, and I've been in contact with Mpox. So what we do is we say, wear a mask, first of all, wear a mask in public, wear a mask before you come to the clinic, wait outside, then we will get all our PPE on, which is eye protection, masks, gown, gloves, etc. And then we'll bring them into the room and do as much as we can in the single room to prevent people sitting in reception, using the toilets, etc., so that we can prevent any potential environmental transmission. So, and one of the things with masks is that there is a potential, particularly if people are quite unwell, there's a risk of aerosol transmission. And so with, and talking about aerosol transmission, one of our doctors actually, unfortunately, had somebody sneeze in his face inadvertently, but luckily was vaccinated and actually didn't get unwell, but that's definitely a risk. So what have we got next? So treating or not to treat. So in general, for most people, there is no treatment. So it's a self-limiting illness. In the majority of cases, people will be mildly to moderately unwell. It will resolve on its own over the period of time of 2 to 4 weeks, as Amy said. So you don't need antiviral therapy. If people are quite unwell, but not suffering severe illness, then analgesia, if they've got some secondary infection, then you can use antibiotics. And if people do have some symptoms of proctitis, then stool softeners are definitely going to be helpful for people to defecate. I had one chap not too long ago who had not been vaccinated. The lesions come up in the rectum, and he said that going to the toilet was like passing glass. So it's another story I give to people to encourage vaccination. So for people with severe infection, and particularly those that are potentially immunocompromised or with other complications, then it definitely needs referral to a specialist, and antiviral medication is indicated in certain situations. So
we just had a question there, Gary.
Yeah.
So in the chat there, so for women, dry swab.
Yeah, absolutely. I guess I'm not being it did pop into my mind a little while ago, but definitely there's a risk for vaginal lesions. There've been so few cases, I guess it's not front of mind, but a dry swab definitely for the solves and the rectal swab. Yep. Okay, so with so in the beginning, any potential case of Mpox, this is going back to the first big outbreak in 2022, was welcome Lisa, was kind of a panic, I guess. Could this be a big issue? Which in 2024 it was designated as a World Health Emergency by the WHO. So not an unserious infection. So we need to tell people, as with all the other STIs, that Mpox is automatically notified to public health. And if they are confirmed positive, and particularly if they're severely unwell, and they will liaise with the clinic on this as well, that they may be contacted by public health to facilitate contact tracing. So, and yes, I've already said they'll automatically be notified. So in the beginning, we had to call public health, we had to call the on-call microbiologist at Pathwest, for example, to say we've got a potential case, we're sending samples, let the lab know, ... That's eased off a little bit now. So because public health will be automatically notified. So that's not quite as urgent unless you think somebody is severely unwell and there is significant risk to other partners. So if people have, a few lesions that are easily covered, in the beginning, again, even if it was mild, we'd say stay home, don't touch anyone, don't go anywhere. But if the lesions can be easily covered, then that's fine. They need to avoid touching the lesions, clearly abstain from any sexual activity, and good hand hygiene, cover nose and mouth. And if they've got, some moderately to more severely unwell, definitely wear a mask because of the potential for respiratory droplet transmission. Struggling today. Anyway. So obviously avoiding contact with people that are immunosuppressed, young children, and people that are sharing in a house. It's avoiding sharing personal items. Make sure that you wash and clean and dry your own dishes, not sharing any of those other items. So I think. Oh, also this is one important thing. Is I think Amy mentioned before that all the lesions have to be completely healed with nice brand new skin underneath before people are considered non-infectious. So they need to definitely be aware of that before they resume normal activity. So it's not really known how long the virus will remain in semen and other fluids. So for a further 12 weeks after people have recovered, it's recommended that people use condoms for oral, anal, or vaginal sex to reduce any potential risk of transmission.
Of course, we recommend using them in general to prevent any other STI transmission too, where we can, we're encouraged.
Indeed, indeed.
So that's always a good point to kind of reinforce that message as well.
Yep. Okay, so prevention. So some people will tell me, ask me, how do I avoid getting any of the STIs or Mpox? And I say, well, stop having sex. That's not going to happen. So, so what we can do is harm minimization, risk reduction. So reducing number of partners if possible, having regular partners so that they're easily contacted is one way. And also the vaccine, which is provided free for anyone within the specified criteria of people who are eligible and any healthcare workers that are potentially going to be exposed to Mpox. It's free. And the overall efficacy of the vaccine after the second dose, about 2 weeks after the second dose, then the average immunity, so you've got to average it out across the whole cohort, is about 85%.
Sorry.
Right.
Cool. Yeah. Cool. So I had little gremlin there. So no, it's not 100%, and no one can ever say that any vaccine is 100%. But with 85% protection, you've got already good circulating antibodies, and any exposure and illness will be a lot less severe than if you were not vaccinated. And we had one chap, bless him, just didn't want the vaccine, and had a really severe outbreak. So. But he will be immune now, so we don't need to worry about following up on vaccines for that, which is important. Some people ask you, do I need a booster? The recommendation currently is 2 doses. That's it. That's all that's needed. So the cohort that we want to target the vaccine for, all sexually active MSM, sex workers, and which I think should include all sex workers, because even if you've got inverted commas, heterosexual client, often they're having sex with men as well. The people living with HIV and at risk of Mpox exposure, sexual partners are the above. So if people have, sometimes people in open relationships, and they have a female partner and other male partners, then they would also be eligible because they would be at potential risk of Mpox, lab personnel and healthcare workers. So, anyone who's working that may be at potential risk can be vaccinated. So with the vaccine, so for specialised sexual health clinics and specialised GPs with high caseloads, there is no limit basically on the number of vaccines. So the minimum we order is 20. When we've had high uptake, we've ordered up to 80 vaccines at a time. There is limited short expiry because it's frozen and has to be reconstituted. So usually the expiry is within a few months. And obviously it does require cold chain management. For GPs in general, regional and other suburban GPs, the order limit is set at 2 doses so that the vaccine is going to be targeted to specific cohorts. We had one GP who sent somebody to us, requesting that we give the vaccine because he was going to be working in Africa. And not a man who has sex with men, was simply going there. So it is not a travel vaccine. It's only within the criteria that we've already discussed. So if GPs think, oh, actually, I do think I've got a few people that are at higher risk, they can put in an order through the One Link website. And if they need more, it would be good to contact the vaccine people at the Department of Health. If they do put in a larger order, then that will be reviewed by the vaccine management team. So with anyone that might be presenting, you think they might be at risk for Mpox, or you think they're symptomatic from Mpox, and they haven't been vaccinated, automatically offer the vaccine. If people turn out to be positive for Mpox, then you don't need any further doses. If people, again, have been confirmed contact of somebody who was symptomatic, then vaccination within 4 days will provide a high degree of protection against developing the disease. So that's always a good thing to keep in mind. What else do we got?
There's also on that as well with in terms of the vaccinations, if your clinic doesn't provide doesn't currently provide Mpox vaccinations, there is, if you go onto the Healthy WA Mpox page, they have got a list of clinics that they are known to stock the Mpox vaccination for both metro and regional. So within the metro area, so M Clinic, Royal Perth Sexual Health Clinics, the one in Ainslie House, SHQ, South Terrace Clinic, GPM Beaufort, Central City Medical Centre and View Street Medical are the ones, the providers currently listed for the metro area in WA. Then for regional areas as well, the vaccine is still available for free for people through their regional public health units, or if there's any participating immunisation providers. So the first point of call would be through the public health unit to access the vaccination. So if you do have your clients coming to see you, you think might benefit from the vaccination and have those conversations, then there is navigations or avenues that you can refer them to access a vaccination if that's not something that you're able to provide in your practice as well. Anything else in the
I think that's good. No.
Cool. Lastly, we've got some messages here. When we were first kind of popping these together, we were thinking of both messages that we can take away from today, but also some messages that we can pass on when seeing clients, talking about particularly around the vaccine efficacy and vaccine hesitancy that might be around, and what we can kind of some messages that might help to endorse getting the Mpox vaccination as well, and also testing too. So the first one being, if you aren't sure, test for Mpox anyway. So if you aren't sure, like Sarah was saying, if someone's presenting with symptoms that could be characteristic of Mpox and you're not too sure, you're testing for other infections as well, testing for Mpox is encouraged. Similarly, especially if there is any kind of the epidemiological evidence that could indicate there could be Mpox as well. So testing for Mpox there, and again, on the same swab, you can include that testing for syphilis and also for herpes as well. So vaccine is available. It's highly effective, with high efficacy, and has minimal side effects, if any side effects at all as well. In WA, as you can see, we don't have high rates of Mpox. Whilst we have kind of followed the general trends with the outbreaks from 2022, particularly then into 2024, people may say that, Mpox, we don't have many Mpox cases. That, is something that maybe people need to be worried about. The reason why we don't have so many Mpox cases is because of the higher rates of vaccinations and people's awareness around prevention, including vaccinations and getting tested as well. So it's because of those efforts and that knowledge that we have been able to keep rates low. So if we just kind of take our foot off the foot off the gas there, and kind of put it in the back of our minds, I think that it's not anything to think about, then as we've seen with other kinds of infections, that we may see rates increasing, which we don't obviously want to see. And obviously people don't want to experience that as well. Again, with symptoms can be moderate to severe symptoms, and they can be painful, but these symptoms can be prevented as well. So as Gary was saying, with the vaccination, it may not prevent somebody from necessarily getting Mpox, but it can greatly reduce the symptoms and the severity of the disease that somebody experiences, of course, which is for quality of life and experience of it. We obviously want that for our clients and the people in the community that we see. And again, similarly, other things that can be prevented too. So the bacterial infections of lesions that can cause scarring and that kind of lasting cosmetic kind of damage there it can cause too, and other complications that can come with scarring. But again, this can be prevented too as well. So again, through vaccinations and severity of the infections, but also accessing services, getting tested to prevent preventing the onset of these bacterial infections, or also getting that intervention early enough to prevent these scarring and other kind of less desirable kind of outcomes there as well. And again, so I said that you can still get the infection if vaccinated, but it will be less severe as well.
I'll just jump in as well. Understandably, a lot of people are concerned about potential side effects, as with any vaccine. A lot of people had quite unpleasant side effects after the COVID vaccine. So a lot of people were saying, oh, this is a new vaccine. It's like, actually, no, it's not new. It's been around for a very long time. It's just become something that people are more aware of because of the worldwide outbreaks. And of course, as soon as it affects Western countries, let's get onto it. So with the vaccine, most people will not have any significant side effects. I've had 2 people that had quite a significant rash. Now, it is given just up here for those healthcare workers, subcutaneously. We just do it at the back of the arm. Some people, a lot of people, when I had mine, come up with a red itchy lump, which I found very annoying, but the lump took a while to go away. You can reassure people that will go away, and always show them my scary photo and say, well, we're still preventing this. I've had maybe a couple of people said they had some following sort of muscle aches, pains, flu-like symptoms, but very, very uncommon, and we have literally done thousands of vaccines. So I think that's a good way to reassure people as well.
There's some resources that the Department of Health have created for healthcare workers and also for community as well around Mpox. I'll send out the PDFs of these in the follow-up email with recording and any other information too in the next couple of days. So this I have here a quick guide around particularly for primary healthcare workers around that testing for Mpox. And there is also a little printout of it. It's a little fact sheet, a 2-page fact sheet for information for people waiting for a test result as well. So this goes through explaining what Mpox is, what to do if you have a positive result, and also what do I need to do around vaccinations and around the kind of the precautions that we were talking about there before, if somebody does come back with a positive result, to prevent kind of onward transmission as well. So there are these resources. They are new ones that they've released too. They used to have little wallet cards, but I couldn't find an example of that. We have some at the office, but I couldn't find, so I don't know if they're updating them or maybe they're not using them anymore. But there is information there that we can use and that you can download there from the Department of Health, and resources there in your practice. So that brings us to towards the end now of our the formal part of the webinar today. So we do have a list here of some services. I'll send out the slides too at the end when I send out that big email in a couple of days, just with some sexual health healthcare for the community, information around HIV and STIs, information for clinicians more broadly, and then also any other social support and mental health supports as well. If you have any questions about any of these, you're welcome to ask us. Otherwise, we have the information there that'll be sent out afterwards. But that does bring us to the end of the formal part of our webinar today. So we will stay online to take questions. We have here the QR code for the evaluation form, and I will also send through, if you're not able to scan the QR code, I will send through in the chat in a second. There will be a link there to complete the evaluation form online as well. Again, we do really appreciate any feedback you have to provide, so how we can improve these sessions. If there's any topics as well that you would like us to cover, we would love to know what we'd be able to provide to help your practice. So we have some ones in the works at the moment, some plans, but of course we'd love to have some input and some guidance by what everyone's needs are as well. So we will stop the formal recording, and then if you have any questions, you can either raise your hand or pop them in the chat, and we can have a bit more of an informal kind of conversation there.
Okay.